Hello, and thank you for joining today's webinar titled Peer-to-Peer Vaccine Education and Outreach Program. This webinar is brought to you by the Canadian Public Health Association through the CANVax project. I'm Aishwarya Shah, CANVax Project Officer at CPHA, and I'll be moderating this webinar. Before we begin, we want to acknowledge that the Canadian Public Health Association's office is situated on the ancestral and unceded territory of the Algonquin Anishinaabe people. They have been the guardians of this land for millennia, and we are grateful for the example their stewardship provides. CPHA is committed to working with all First Nations, Inuit, and Métis peoples and their governments in realizing meaningful truth and reconciliation. Now on to some housekeeping items. This webinar is taking place on Zoom and all attendees are muted. If you have questions regarding technical difficulties, please contact canvax@cpha.ca and we will reply to you as soon as we can. If multiple people are experiencing the same problem, we'll address it live via broadcast message in the chat. That being said, the host will use the chat tab for extra communication to all participants, so please keep an eye on it as well. As for the questions and answers session of this webinar, please submit your questions for the presenters in the Q&A box at any point during the webinar, and they will be answered at the end of the presentation. Finally, before we begin, 3 quick notes. Firstly, this webinar is being recorded and will be made available on CPHA's YouTube channel and on canvax.ca. And the presentation slides will also be eventually shared. Secondly, we invite you to take a short 5-minute post-evaluation survey at the end of the presentation to provide your feedback on the delivery of the webinar. Finally, if you haven't already registered with CANVax or subscribe to our newsletter, visit canvax.ca to do so. And with that, let's begin. We have the pleasure of welcoming the Peer-to-Peer Vaccine Education and Outreach Program team from the Niagara Folk Arts Multicultural Center. This is a program that provides information and education sessions to newcomers in Niagara so they have access to culturally and linguistically evidence-based information when it comes to vaccines. Our first speaker is Ahmed. He's a curriculum development and research manager of the Peer-to-Peer Vaccine Education and Outreach Program. He has completed his Master's of Public Health from Brock University, and he's also working with the he's also working with the Youth Wellness Hub Niagara as a youth navigator. Ali has had a full circle of experience at the NFAMC, where he was working as a youth worker and a mental health support worker. Our second speaker is Daniela Gotera. She's a Spanish vaccine ambassador for the project. Daniela earned her bachelor's degree and postgraduate degree at Zula University in Venezuela. She is currently working as a physician's assistant in a walk-in clinic and volunteers as an interpreter. Daniela is an internationally educated health professional, and she's in the process of acquiring her license to practice medicine in Canada. Our third speaker is Johanna Ravello. She's a registered nurse from Venezuela, currently working at the LaSalle Hospital in Montreal. Johanna has a diploma from the Central University of Venezuela. She has joined the Peer-to-Peer Vaccine Education and Outreach Program as a French vaccine ambassador to share public health information in people's primary language. And our next speaker is Mzin Idris. She's a health education outreach worker. Mzin is currently working towards obtaining her Master's of Science in Applied Clinical Nutrition, and she joined the Multicultural Youth Action Council, a platform that strives to encourage youth volunteers and community engagement in Niagara. Finally, we have Lina Wang. She's the Mandarin Vaccine Ambassador. She's an internationally educated nurse, graduated from Henan University in China, and obtained a bachelor's degree of science in nursing. Lina has worked in several areas of nursing, including emergency care, pediatrics, and Gynecology at the Shanghai University Family Hospital. Lina is currently studying nursing courses to obtain her nursing license in Ontario. Now, I would like to turn it over to Ali to begin the presentation.
Awesome. Thank you so much, Ashwarya and Antonella, for organizing this webinar and doing the introductions. And I will share my screen. Okay. So I want to thank the participants that were able to come to our webinar today. It is with great honor that we can present our project on the peer-to-peer vaccine education and outreach program. And we hope that you enjoy it and that you learn something from it. And at the end, we'll have a Q&A for you guys to answer, and I will begin. This is an overview of things that we're going to be talking about during the presentation. I will be talking about background information, how it all started, the project, community outreach efforts, survey results, vaccine hesitancy barriers for newcomers, the international educated health professionals experience running sessions. So the 3 IEHPs that you've seen, Johanna, Daniela, and Lina, getting their experiences, best practice guidelines and recommendations based on our project and what we would like to see going forward. And then there'll be a Q&A at the end. So a little bit of a background. This project started 1.5 years ago in September 2021. This all started from a summer initiative when probably COVID was at its highest. So we got approved for a $10,000 grant, and we had IEHPs run sessions, and it showed an improvement in knowledge, showed an improvement to share information among newcomers. So using that, we applied for a grant, and then we were able to get a 1.5 year pilot project with IPF to expand it and see more of our results. So the purpose of this program is that we wanted to positively change knowledge, attitudes, and beliefs for newcomers and increase or have an increased uptake in COVID-19 vaccines, but do it in a culturally and linguistic appropriate way. So this is where the peer-to-peer support model comes in. Having someone that speaks the language, but also knows about it like culturally as well and can relate to the newcomer experience. So we found that this was an important initiative to see, like, is that really helpful for the newcomers? Do they really gain more knowledge? And also an additional focus is that we wanted to identify gaps and barriers in the newcomer population and learn about the international educated health professionals' experience running sessions. So the reason why we did it is that there are challenges for newcomers regarding getting vaccine information, and they're more likely to be vaccine hesitant. And some of the reasons, the 3 determinants are complacency, so perceived low risk of getting disease, confidence and trust in the vaccine. This could be due to the healthcare system or the healthcare provider, feel like they're not being listened to, and convenience, so not having culturally and linguistically appropriate services. So this is something that we tried to tackle during the project and aim to get better results, have more trust in the healthcare system, have an increased level of cultural and linguistic services in order for newcomers to feel more comfortable getting the vaccine. And our plan and execution, this was, we had an evaluation plan that allows for identification of needs, systematic gaps and barriers, and also research and methodology. And we also partnered with Brock University and Dr. Joanne Crawford, who is a nursing professor. We got approved for a research ethics board application in January 22. before the start of our sessions. And this allowed us to make sure that we're not taking advantage of the newcomers and that it's ethically sound, the surveys we're giving to them, the questions that we're asking. So we were able to do like pre, post, and follow-up surveys, etc. So a little bit of context. For our project, we defined newcomers as first-generation immigrants, so people that were born abroad, but also second-generation immigrants, because they were often left out of this definition, where at least one parent was born abroad. And this definition was adapted from the International Organization for Migration. And we include the second generation, obviously, because it's an overlooked population. And this together makes up about 40% of the population in Niagara when we include first generation and second generation. Our target population was 12 and above due to, at the time, the Pfizer vaccine being approved for youth age 12 and above. So that was our market, and we had existing programs at the folk arts like the youth group. We have a senior group. We have ESL classes, settlement, job search, mentorship, mental health support. So it was embedded in all that. And then our newcomer population in Niagara is composed of landed immigrants, refugees, and caregivers. And we know that this population is most likely to be racialized, experience discrimination, food instability, social isolation, and have less access to healthcare. Okay. And this was an introduction video that we started at the beginning of our program. It's an animated video and it gives you a little bit of insight. So we partner with the 180 social marketing team, and I hope you guys like it. So this video was used as social engagement strategy for newcomers, but also for our community organizations and partners to attract them to the program, to get more newcomers to sign up, and for people to come to our social media, to our Niagara Folk Arts website, and come and see what the program is all about. So about the pilot project. So it was based on 5 things. The beginning part is existing programs. So this was an advantage of being a settlement organization. So we already have newcomer clients already participating in our programs. So as mentioned before, we have ESL classrooms, we have settlement, we have youth group, skills training program, mentorship, mental health support program. So this allowed us to have high recruitment and to communicate with staff members for outreach regarding like if it's an email blast or communicating with our clients one-on-one. So we had a lot of opportunities to present in front of them. But it was not only limited to our program at the Niagara Folk Arts, it was also for all newcomers in Niagara. So we reached out to community organizations and partners to make sure that they knew about our program and that their newcomers could visit. So we done sessions like in Fort Erie Multicultural Center, and I think we've done a few in Niagara Falls. So we try to branch out to other newcomers organizations and have the newcomers attend remotely or in person. And this enabled greater access for everyone to be part of the program. So our program also concentrated on research. So our educational and outreach PowerPoint presentations, this was adapted from evidence-based health information. So we got it from public health, we got it from government, we got it from health organizations, we got it from scholarly peer review articles to make sure that we have the most up-to-date information that we're giving newcomers. And during that time, our international educated health professionals, they would go through the PowerPoint with me and they would suggest, I don't think we should include this. Maybe we can make it more culturally linguistic this way. So they had a good input on what to include and what not to, and they did their own research as well. And in partnership, we did partner with Dr. Joanne Crawford from Brock University, as mentioned before, and this allowed us to do research at a high level and high standard for newcomers to be treated fairly. And during our management, we used a program called Qualtrics, was a management company that allows us to create pre-survey, post-surveys, follow-up surveys, our consent form and invitation letter. So before newcomers could even participate in the survey, they would have to give us the consent. If we didn't get it, they wouldn't participate in the survey. So we did this to protect their identity, give them a unique ID. And we felt it was easy for them to they can switch the language if they wanted Spanish or Mandarin survey, Arabic, and it was just a click of a button. So it was easy to use. And then we had education and outreach sessions. So for our educational sessions, there was 5 total. It was COVID-19 overview, media literacy, building confidence in the healthcare system, self-care, and getting back to a new normal. Not all the topics have the word vaccine in it, but they all covered vaccine. There was some vaccine fatigue towards the end, so it was good to embed some of the topics into other topics and programs that they were interested in, but also bring in the vaccine component. We also did community outreach, so reaching out to community organizations and stakeholders, ethnocultural groups, animated videos, infographics, etc. And that's something our outreach worker will talk about in a little bit. And then we have the IEHP and newcomer experience. So we wanted to learn the barriers that are in the system. We wanted to see the experience of the IEHPs. How was it to run educational sessions? So we had focus groups with them. We identified barriers, and we submitted an REB application for that as well. So I will pass it to Mzin, our community health outreach worker, and she'll be talking a little bit about the community health outreach efforts.
So a huge component to our project was letting those in the community know about it so that we can spread awareness and ultimately recruit participants to partake in the research study. So I'll go more in depth regarding how we went about the outreach efforts. So our outreach efforts consisted of reaching out to external and internal resources or sources, as well as utilizing social media. So at the beginning of the project, way before we started the education sessions, we reached out to all the ethnocultural groups, stakeholders, and community organizations across the Niagara region, informing them of this novel project that we had going on at the Niagara Folk Arts. We let them know what this program had to offer and what we hope to accomplish through it. Many of the groups and organizations that were interested reached out to us to find out more information and how they can help. In addition, we also reached out to newcomer clients that were internal to our organization. We created an outreach tracker to keep track and record all ongoing efforts. Things like when initial contact was made, the contact information of external sources, if and when meetings took place, and if promotional materials was provided, were noted in that tracker. We noticed some benefits and also some challenges during the outreach efforts. We noticed a great positive response to our project in the beginning. Many of those that we reached out to were eager to help out, and a lot of them were receptive to the idea of this program. In terms of challenges, we observed that as we went through the project, the interest decreased and the number of participant registration went down. So we attributed this to newcomers becoming more disinterested in topics concerning COVID and just overall experiencing vaccine fatigue. An attendance and registration tracker was also created to keep record of who registered for the educational sessions and who attended. For the participants that did register, we assigned them a unique ID as it was needed for our surveys. And to protect their identity, only certain people within our team knew which unique ID was assigned to the participant. We collected some of their personal information, like their emails, names, and the language they spoke. And this was strictly for the education sessions. As for the outreach sessions, there were no unique IDs because surveys did not take place. We did collect their numbers and names just for our record and for our data. And in an effort to reach more newcomers and attract participants, we created infographic cards that contained the most up-to-date data in each of the 5 languages to highlight the education sessions. We also then delivered those infographic cards to many of the ethnocultural groups and community organizations so that they can disseminate them among their clients and community members. Social media was another way for us to do outreach. So we shared our infographic cards and other forms of media like the video Ali showed previously through Instagram and Facebook so that we can reach more newcomers. All of our promotional material pertaining to the sessions, flu shots, COVID information was disseminated through our social media platforms. Now, to give you more context, here we try to quantify some of the outreach efforts. So we reached out to about 14 ethnocultural groups and 13 community organizations. And just to name a few, we connected with the Sudan House of Niagara Region, LINCA, which is the Latin Immigrant Niagara Community Association, Armenian Community Center, and many more. As well, we reached out to organizations like Welland Heritage Council, Centre de Santé, the District and Catholic School Board of Niagara, as well as Rocks International Center. So we had a total of 5 education sessions in Arabic, Spanish, Mandarin, and English, with a total of 146 participants attending. So that's an average of 29.2 participants. The 5 sessions covered an overview of COVID and vaccines, media literacy, building confidence in the healthcare system, self-care, as well as getting back to a new normal. And the education sessions began mid-February and finished mid-June. As well, we had about 44 outreach sessions since the start of January 2022, with a total of 372 participants, an average of 8.5 participants per outreach session. Now, for our outreach sessions, we targeted our ESL classrooms at the Niagara Folk Arts, the youth group, English Conversation Circle, orientation to Ontario sessions, as well as ethnocultural groups and community organizations. Internal recruitment was directed towards students and clients of the Niagara Folk Arts, and our outreach efforts were also done by reaching out to teachers, settlement workers, other staff members with specific language connections, and through sessions, like I mentioned, orientation to Ontario at the Niagara Folk Arts. And as I mentioned earlier, we utilize social media to reach out to people. In the past 6 months, we reached out to 10,423 people and generated an engagement of 220. And this would entail sharing our posts, liking, commenting, any of the material that we put out. And again, the promotional materials that we shared included infographic cards, education and outreach posters, animated videos, and vaccine information and anything related to that.
Thank you so much, Mzin, for doing the outreach data. She's been a big part of the program, and without her, our total number of participants wouldn't have been as high. So thank you, Mzin. I'm going to be touching on our survey results. So this was based on our 5 education sessions, and this includes pre-survey, post-survey, and follow-up survey. And we'll be going through that. So the number of surveys that were completed during our 5 education sessions was a total of 95, and 45 different newcomers completed the surveys, which means average number of newcomers that completed a survey is 2.1 from the total, from the 45 to the 95. Our numbers, the people that actually attended the sessions, a lot of them, they did not complete the survey, and that could be due to a lot of reasons. They didn't give consent during the process. They couldn't find their unique ID on time. They came in the middle of session, so they can't do a pre-survey when it's like the middle of the session. So that didn't allow them to do like the post-survey. So that's why our numbers aren't the exact same compared to the attendance, but it was still a good turnout. And these are the total number of sessions attended by newcomers that completed the survey. So a total of 21 people attended 1 education session. A total of 8 people attended 2 education sessions. A total of 9 people attended 3 education sessions. A total of 4 people attended 4 education sessions, and a total of 3 people attended all 5 education sessions. And this is just related to the people that actually completed the survey. Our numbers are a lot higher than this, but it's just based on the survey result data. So based on the survey results, some socio-demographic information, 78% of our people that completed the survey were female compared to 22% male. The majority of the newcomers spent 2 to 5 years in Canada, which represented 49%, and 22% spent less than 2 years. So that's 71% of our newcomer clients that completed the survey spent 5 years or less in Canada. The average age of participants, the age of participants was 53% from 30 to 49 and 27% from 50 to 64. So that represents 80% from 30 to 64. It was challenging to say get youth participants to attend and also complete the surveys, whether they were in school or they've already been told about like vaccines and all that kind of information. So they were less likely to commit and join. But the good news is, even though our demographic was 30 to 64, a lot of them do have kids and they can relay that information, or they have family members or friends, and a lot of them were open to discussing it with them, which was a good thing. Other socio-demographic information. So pre-survey, we put a question, how likely are you to get a vaccine if you're recommended by a primary care physician? And 66.7% of people said if physician recommended, they were likely. But our post-survey went to 80%. So this was a 13% increase. And this was due to the PowerPoint and our IEHPs knowledge from a cultural and linguistic point of view to increase that number, to increase trust in the primary care physician that would recommend vaccine. And then these are the number of COVID-19 vaccine shots. So 14 had 2 doses, 28 had 3 doses or more. So 42 out of the 45 participants got their full series of vaccine shots during the time at the end of the session, June 2022. And I think some of it had to do with the restrictions lifted and them having to take it, but others were open to getting vaccine shots and spreading it to their family and friends. And this is session language participation. We had 40% for Spanish, so this was our largest for newcomers. And then we had 35% for English, 18% for Arabic, and 7% for Mandarin, which falls in line with our the Negro Folk Arts Multicultural Center. We do have a large Spanish population and Arabic, and then Mandarin's a little bit lower. For our French, it was difficult to get education session participants to complete the survey and to attend, because the French organizations were already giving out this information. So when we would reach out to French organizations, they would say, we already doing programs like this, or clients already vaccine hesitant, so they were less likely to come. But we did have outreach sessions for French as well to attract that population. Okay, and these are our education session 1 and 2 results. So we put this data in SPSS based on our survey results for each session, and we did a pair samples t-test to see whether there was significant result for knowledge, beliefs, and attitudes. We've also done subjective norms and medical mistrust as well. So for our first session, COVID-19 overview and vaccine, there was statistical significance between post and pre-survey knowledge, and also post and pre-survey behavior and attitudes. As you can see here, the P values are less than 0.05, showing statistical significance, and also for the post and pre-survey here, which was a good sign. For our follow-up survey across the board for each session, it was difficult to tell whether there was a statistical significance, because the amount of people that actually completed the follow-up survey was a lot lower than our post and pre-survey. We had to email them out. We sent like multiple emails, but some were less likely maybe to complete the whole survey, or they didn't see their email, etc. So even though the mean levels might be similar to the post survey, we're unable to say that it was statistically significant, but we do think that it was. For media literacy, this is our education session number 2. It was statistical significance was shown between post and pre-survey subjective norms. And that is right here, less than 0.05. For knowledge and beliefs and attitudes, it did not show statistical significance. And then for our education session number 3, building confidence in the healthcare system, there was statistical significance was shown between post-survey and pre-survey knowledge. And as you guys can see here, less than 0.001. So we know that this was quite beneficial and it was statistically significant. Regarding beliefs and attitudes, it did not show statistical significance or medical mistrust. Regarding self-care, there was statistical significance shown between post and pre-survey knowledge, less than 0.05, and also post and pre-survey behaviors and attitudes, less than 0.05, showing statistical significance, which was important. And then for our last education session, number 5, getting back to a new normal, there was statistical significance between post and pre-survey knowledge right here, and also beliefs and attitudes. So just to summarize, 4 out of our 5 education sessions showed a statistical difference, statistical significance between post and pre-survey knowledge. And 3 out of the 5 showed a statistical significance between beliefs and attitudes improvement. And although we can't say for sure certainty for the follow-up survey, we are confident that the mean levels line up more to the post-survey. So it does seem like it was maintained after the post-survey for each session, that the knowledge maintained, although we cannot say for certain. And I'm going to pass it to Daniela, which will talk about the vaccine hesitancy barriers for newcomers and the IEHP experience.
Thank you, Ali. So talking about the barriers identified by newcomers, that was the main reason for the vaccine hesitancy. The next slide, please. Thank you. Okay. So the main barriers, we can see everything here. Of course, first one, language. Not having someone to able to talk then in their own language, they feel like they are not being here. Okay. The second, talking about translation service, English and French are the main language that are translated to newcomers language. So there is a lack of new language like, for example, Spanish and Arabic. If we talk about the accessibility, newcomers can often work long hours and have multiple jobs, making access hard to get the vaccine or attend educational sessions. So there is another barrier identified by them. Find a family doctor. Everyone is a struggle about that. So everyone knows that it's hard to find a family doctor. There is a long wait time. I'm finding one that understands the culture and language of the newcomers becomes very challenging. I will say that it's a hidden gem. So in hospitals and walk-in clinics, newcomers often tell us they feel like they are not being heard or brushed off because they do not fully understand the language. Talking about the media, lack of online fact-checking gets passed through WhatsApp, for example, Twitter, Facebook, and the information that is translated into their own language is not always evidence-based. That's another huge problem because they cannot find that kind of information in their regular social media. And last is the stigma. There can be much stigma in people's family and friends to getting the vaccine. That's a main reason to persuading them to not get it. And it becomes more challenging to have conversations with them or to tell people about the vaccines. They identified this like the main barriers. So when we have all this information, that's the reason to all these programs. So now I'm going to talk about my experience. So as a Spanish ambassador in the peer-to-peer vaccine education and outreach program has been incredibly fulfilling. As an immigrant in this country, I know firsthand how difficult it is to access reliable and accurate information in your own language. As expected, when you come to a country, you try to integrate into the culture for sure, the language and the way things are done. But when you find yourself in a difficult situation, such, for example, as a medical condition, in an emergency room, or where you must decide whether your life or the life of a family member can be affected, you appreciate not having to wonder about your accent, or if you understand what they told you. Precisely because that is where one of the significant barriers I mentioned earlier comes from. Language barriers can prevent individuals from seeking healthcare advice from providers, causing them to rely on less trustworthy sources, such as mentioned before, social media, friends, family, putting them at risk of making wrong decisions. I explain this with the purpose to make you understand that the experience with the program has been fantastic. The participants of the Spanish group have been consistent, have good engagement, ask many questions, and stayed attentive during all presentations. They have consistently reported that the educational sessions as a positive experience, feeling relieved that they finally have their doubts clear. This success can be attributed to the fact that many participants may have been hesitant to ask questions in English due to embarrassment or lack of confidence in their English language. Additionally, cultural differences have also played a role, and health personnel have had to learn how to answer questions in a culturally sensitive manner. As a physician from a similar background, I have been able to respond to questions more effectively, ensuring that the information provided is scientifically sound and evidence-based. As a result of this program, vaccine hesitance has decreased, and individuals are making more informed decisions regarding their health and wellness. This program is a necessary and successful initiative for the physical and mental well-being of future citizens, second-generation Canadians, and to reduce the healthy immigrant effect in Canada. That's why it's a pleasure to be here today. And now I'm gonna pass to the Mandarin Ambassador, Lina Wang. Thank you.
Thank you, Daniela. Hi, everyone. I'm Lina Wang, the Mandarin Ambassador. I'm glad that I joined this program to help and support those who have barriers to accessing reliable health information. And I have received some positive feedback from the participants throughout the presentations. And they found this program very helpful and supportive, as they have got reliable health information and knowledge, including COVID-19 vaccines and self-care strategies, and as well as emotional support during the pandemic. And this helps them to make informed decisions during the most difficult time. And also there's similar backgrounds we have and make it easier for us to build a trusted relationship. And also the discussion sessions in the presentations and allowed us to discuss our experiences and share our feelings and to better support each other. I think it is very effective to deliver health information in such a culturally and linguistically appropriate way. Also, I have learned lots of skills and also learned resources for searching evidence-based information. I believe this experience will be helpful for me to support this population in my future job as a nurse in Canada. And thank you everyone. Now I will pass to Johanna. Johanna.
Hi everyone, my name is Johanna Ravello. I'm the French ambassador in the vaccine project in the Centre Niagara Falls Art Multicultural Center. And I'm a registered nurse too in Montreal. For me, it's as a privilege to be in the program because it's an opportunity to bring out knowledge as immigrant health professional to newcomers and like an immigrant too. And the best thing is to be able to do it in the old language. We know everything about the barriers, language, and like a professional too, I know in the first place how it's difficult to the people that come in here to explain everything and to be able to have the information. Thus, for us, we're born in Canada and speak the language. When at first we came here, we know how difficult it is to do everything. In my experience, like a French ambassador, like Ali explained before, it was a little difficult because they already a program vaccine. But I have the participant, and when I have that, it was excellent, it was amazing, and the people is all the happy to find the information and have the information in their own language. And it's been magnificent for me, and I think they could be more of these types of program across the country to broaden the proper knowledge about the vaccination and the very integrate the newcomer. So this is my experience that I passed to Ali. Thank you so much.
Awesome. Thank you, Daniela, Lina, and Johanna, for mentioning your experience running sessions. They were a great help to the program, helping with the translations to our PowerPoints and to our social media, and providing evidence-based health information. We've got a ton of emails after sessions in like Spanish and French and Arabic and Mandarin. And I was always going to them like, can you answer this and answer that question? Because a lot of the newcomers, they had a lot of questions to ask after the presentations, and we were able to provide that and also the PowerPoint if they needed. So we have a couple slides left, so I'm just going to touch on our emerging best practices that we found during the program. And it was based on 6 key learning factors. So something that we found: international educated health professionals providing services in first languages provided a culturally and linguistically appropriate way for newcomers to learn. Evidence-based health information. The use of translation services is imperative. It helps newcomers to be engaged and share materials with their loved one, whether it's on WhatsApp, on WeChat, on Facebook, Instagram, to have that ability to do that. And like, so we talk about like, where do you get your flu shot? Where is the booster shot necessary, etc. And they could just share that information right away instead of sharing other social media things that may not be fact-checked. We talked about trainings for international educated health professionals are really important, especially during the remote/hybrid role that we played during the program. So being able to learn things like Zoom training, Google Drive, how to use Google Drive, how to use PowerPoint, speaker presentations, and being able to go on LinkedIn Learning gave them the opportunity to learn from themselves. And we had our skills training staff at the Folk Arts help during this process. Also, having community space was super important because it created a physical and social environment where newcomers feel comfortable being in a settlement agency that they already know, and they get support from peers in similar circumstances. And we found that this increased well-being and also increased participation. The importance of using a hybrid model. You can reach different cities that you might not if you're just located where we are, like in St. Catherine. So being on Zoom gave us the platform to do it. Although we did go inside the Folk Arts into other organizations to deliver presentations, and also extending hours. So having morning and evening sessions. A lot of times we would run 2 sessions, from education sessions, sometimes outreach sessions, to make sure newcomers have the ability to attend, because a lot of them, they're working 2 jobs, they have kids in school, they're in class. So we had to try to find ways where they could get the information. So we always try to make that happen. And an emerging best practice is getting an ethics review application completed before the start of the program. Not only does it give you a timeline to go with, but it ensures that the newcomers are looked after, and oftentimes that's not always the case. So we want to make sure that we're following certain ethics, the questions that we're asking, the practices that we're doing, the gifts, if we're advertising like gift cards, etc., that it's done in a way that makes the newcomers feel safe and comfortable to attend sessions. And then these are our recommendations. We want to support approaches to promoting cultural and linguistic appropriate services across systems. So this includes health, social service, settlement, education, through developing, enhancing, and coordinating partnerships between sectors. So we're a settlement sector, but we talk with Niagara Region Public Health, we talk with Brock University, Niagara Health System. So we want to make sure that we have these partnerships because they're dealing with newcomers as well too. So if they need services, if they need information, we can help them and they can help us in order to best advocate for newcomers. We want to support policies that make it easier for IEHPs being able to work the profession in Canada. Like they go through so many hoops, like trying to like get their profession here, their license here, whether a physician or nurse. I know so many people, and I've heard during the sessions that people come here, they're a physician, and then they're doing all these tests and all these things, but then they have responsibilities for their own selves. So like sometimes they have to work like taxi, do retail, because they have to provide for their family. And a lot of times this gets lost. It's not that they should skip the process. They should still have a process, but let's say for medical schools, there should be more spots open for IEHPs. There should be helpful for like training or like supports in the hospital where they can shadow doctors or nurses so they get that level of experience, because they do have that knowledge and they do have the ability to do it. And as you see here, like Johanna, like she's a nurse and like she's doing such a good job, but I'm sure like she didn't want to have to go through all those hoops and all those things. And then because they are educated, and it's just about creating a fair platform for them. And also we want to support education and training. So providing public education campaigns that are directed at diverse groups of immigrants on health evidence-based information, provide trainings for international educated health professionals, and making sure that they have input on health education that newcomers will be receiving. And lastly, we'll want to support longitudinal and comparative research of international educated health professionals as a peer-to-peer support model towards newcomers when delivering evidence-based health information. So we want to make sure that that information is out there in the research, and the more research we do and it shows that the IEHPs do have an impact on the newcomers' health, the better it will be for it. And that is our presentation. So thank you very much.
Well, thank you to the team from Peer-to-Peer Vaccine Education and Outreach Program for a wonderful presentation. At this point, if you have questions, please submit them using the Q&A feature. As a reminder to everyone, you can also submit your questions anonymously. Any questions that are answered live will appear in your Q&A window under the All Questions tab. So it seems that we have 2 or 3 questions here. Okay, so the first one is, what were the questions in your survey? Were they only about knowledge of COVID-19 or other needs as well?
Yeah, so that's a good question. So we had 2 different categories usually. So we would test, obviously we had socio-demographic information, and then we'd have a section of knowledge, like I think 7 or 8 questions, and then we'd have 5 questions on behaviors and attitudes. And then if we had subjective norms, we'd have like maybe a couple questions there. So knowledge, we just wanted to see where they were at with COVID-19. Like, did they know that like this was a virus? Did they know that it can be spread? Did they know that it's important to socially distance? So we tested like their root knowledge on like factual things, like, so they had an option of yes or no. So we wouldn't leave it ambiguous. It was more like, am I able to get the COVID-19 vaccine? Like that kind of thing. And then behaviors and attitudes was like, I could be like, I'm worried about getting the vaccine. And then it would be like, strongly disagree to strongly agree. And that would be based on a 1 to 5 system. So we tested both parts out for that.
And the second question here is, your sessions were only for 1 language speaking groups or for all of the groups?
So during, for example, so we had COVID-19 an overview for our first education session. So that session would be in English. So I would deliver that session in English. Joanna would deliver that session in French. Daniela would do it in Spanish. Lena would do it in Mandarin. And our Mansour, our Arabic vaccine ambassador that couldn't come today, would deliver in then. So we'd have, maybe it was like the same times we were delivering the session, but it would be different Zoom links depending on which language that they wanted to attend to.
Okay. Yes, I think overall the work that the team is doing is great. And on that, there is a comment here in the Q&A. It's from, I think, a healthcare worker or someone based in Calgary. And they said that I'm based in Calgary, and during the same period that your pilot project was doing similar work, I was puzzled at the time to discover how little immigrants knew what a vaccine is and how it works. People did not comprehend how people could still catch the disease after vaccination. It was also terrifying to discover what lies or fake news they were hearing at church or on social media. We also had a positive impact on reducing the barriers and encouraging more immigrants to get the vaccine through information in simple English and first languages. Kudos to all of us across the country. And she said, thank you so much for the presentation. So I think overall, the work that the team is doing is great.
And I just want to touch on that media literacy. So our second presentation was on media literacy, and we went over myths and facts. And it was surprising, like the amount of people said like true, like the vaccine makes you magnetic, or it gives you certain things, or like the government is trying to control you. So we addressed like these certain issues, and social media was always a big thing. Like they would get all their information from WhatsApp or WeChat or Facebook or Twitter, and they would just tweet it out and then they send it to their friends, and then it just circulates. So I like how you mentioned the social media part. So, and good job with your project as well.
Thank you again, the peer-to-peer vaccine education and outreach team, for the webinar today. The presentation was wonderful. As a quick reminder, please don't forget to fill out the survey upon closing the webinar window on your device. We look forward to your feedback so that we can make improvements based on your suggestions. Thank you, and have a wonderful afternoon, and stay safe.